So my brief is basically to talk on implant and technology choices for unicompartmental knee. We are all convinced that unis are definitely better as far as early recovery goes. Post-op morbidity is very low and shorter hospital stay, lower blood loss as we've seen. So we need to understand what is the progression of OA. Medial osteoarthritis, and this is the phase that stays for a longer time, and this is our target area for a unicompartmental knee. Then we have the osteophytes that form in the notch, and also the anvil that basically impales into the ACL, which causes ACL elongation and a tear, which then leads to subluxation and tricompartmental OA. So this is the natural progression of osteoarthritis, and that's what we'll see further as well. Evolution in unis have been manifold. I'll be speaking mainly on the implant designs and the technology choices that we have now. So the story starts in 1940s with early interpositional devices that were devised for unicompartmental knees. Then Gunston came in with the first modern unicompartmental knee, which was a polycentric knee with a poly implant. But this led to early failures as well. So then Gunston came out with this polycentric implant with an all poly tibial tray, which led to early failures. Then came Marmur's in 1970s with a single peg design. This was a revolution at that particular time with an all poly implant, but this also led to early subsidence. And then he came back with a metal backed implant as well. At this point of time, we have got mobile bearing options, which are many in the market, fixed bearings, many options in the market. Now we'll try and head-to-head compare a few factors in all of these implants. So all poly versus metal backs, all polys led to early failures, especially within 2 years. Therefore, metal backed are preferred these days. Cemented versus cementless. Cementless components have begun their use in 2009. Advantages is that there's no cementing errors. There are no cementophytes, which can cause pain, impingement, and dislocations. There is lesser necessity to revise because of a mistuted understanding of physiological radiolucent lines. That's what we'll see. So there are no radiolucent lines in a cementless implant and a shorter operation time. Physiological radiolucencies are lucencies that are seen in cemented implants, which are less than 1 mm, and they are pretty much demarcated with a sclerotic margin at 1 year follow-up. So if we see them, please do not mistreat them as loosening and revise. If you use an uncemented implant, at 2 years, if the patient has got pain, only then can we consider about a revision. But before 2 years, it's the more remodeling that happens, and therefore do not be in a hurry to revise in the first 2 years. Fixed versus mobile bearings. Mobile bearings, yes, as we all know, they are more congruent bearings. The lesser point contact, therefore, the poly wear still happens, but it is abrasive and adhesive. The mobile bearings, technically, as we have seen, they are slightly difficult because we need perfect balancing. If we put the knee too tight, we load the more lateral compartment, therefore early progression. About bearing dislocations, we'll have a follow-up talk coming up soon. Fixed bearings, they are flat poly tibia on a round femur. So you have got point loading, and therefore you have got surface poly wear in the form of deformation and delamination. When we compare mobile and fixed bearings, there's no difference in the functional outcomes or in alignment as we can see it. However, failure mechanism due to early bearing dislocations happen as early as 0.6 years in a mobile bearing. So if you're through with the first year of mobile bearings, you are sure to have a long-lasting result. At 8.3 years, you can have a poly which is failing in a fixed bearing. Lateral compartmental knee, we'll not talk much, but just an anatomical difference between the medial and the lateral is that the lateral tibial plateau is more convex, and therefore we have got a more femoral rollback on the lateral side. So unlike the AMOA, which happens on the medial side, we've got more wear on the central and the posterior aspect in the lateral side. This is what I call the golden equation. The success to surgery is the knowledge, that's how we plan, then we execute, then we validate our execution and then re-execute again. So what were the limitations of conventional jig-based UKAs? There was an interpatient variation. There could be a variation in the position of the jig, as we've seen. There's no intraoperative real-time data. Then you can have a saw blade which impales into the soft tissues. You can have a malpositioned implant. And therefore, the case volume is very, very important, as Dr. Rajgopal sir has already mentioned. And then you have bettered your skill and then your technical outcome. I want my results from day one. And therefore, that is the birthplace of technology. So even if I don't have that kind of a caseload, I want accurate results. And therefore, we have got these options of computer navigated, then patient-specific instrumentation and robotics. So what all of them gain for us is accurate placement in Kennedy's zone 2 and C. So that is the undercorrected varus loading that we would expect. However, malalignment would be in zone 1 and 3. So CAS has been introduced in 2000s. It has led to better implantation in zone C. There's no difference in functional outcome as regards functional scoring in computer assisted versus conventional. 3D printed patient specific instrumentation. Yes, now we use something called an additive layer manufacturing. Instead of milling a block, there are multiple layers which are fused together, which is more cost effective and more accurate. The 3D printed PSI work on a principle that the jig that is manufactured should fit only in one particular position that it is meant to. So these are built on MRI-based guides, but the lopside is that they cannot be validated on a sterile bone model on table before instrumenting on the patient because it is MRI segmented. The CT-based PSI have got a good 3D model on which you can experiment or apply the jig. But however, the lopside is that when you are placing a CT-guided PSI on a patient, you've got soft tissues coming in. The answer to that is you remove a lot of cartilage and then it can be placed, or you can have a distal bony landmark, as we can see here, the malleoli, to fit your PSI. Technically, there is no difference between the functional scoring in a 3D printed PSI as regards implant positioning, gait patterns, and functional scoring as regard to conventional. But the advantages is that you can have a lot of OT space that is free because you know that this is the inventory that is required for that particular patient. Disadvantage, it is a non-weight bearing static PSI that is created on the basis of a CT or an MRI. Therefore, real-time tracking and ligament tension has to be managed by the surgeon. Robotics. Now we come to the part that is lacking. So we want calibrated execution or validated execution that was not there earlier. And therefore, that is the birth of robotics. So technically, malpositioned implant lead to poor implant survival. This is the premise that has led to robotics for accurate placements. So definitely, we have a better alignment in place with robotics as regards the placement of the joint and the native joint line as well. They say that the learning curve does not affect the outcome. So even if you start off and you have the correct planning in place, you will have still better results or accurate outcomes. You require as little as 6 operative cases for you and your team to get comfortable with the robotics in this situation. Therefore, it leads to a low volume surgeon having high accuracy. This is what we would all want to have. So there's better soft tissue balancing, real-time data that is present through the arc of motion, and we can temper in degrees or in millimeters as well. There is no difference in the functional outcomes as regards conventional as robotics, but better satisfaction scores. That's what this paper says. And there's no difference in implant survival between robotics and conventional at this point of time. Limitations of robotics, we are all aware. It leads to a substantial cost to the patient and the hospital. It leads to, we need to have a preoperative CT scan, which has got a radiation exposure to the patient. We require further training to the surgical staff, increase operative time, especially during the early learning curve. It requires additional incisions for your registration pins or trackers to go in. It leads to increased risk of infection. That's what a few papers say. And this is under contention in the latest literature right at this point of time. And of course, at this point of time, most robotic softwares are closed. We can have them only for a particular company implant. So I thank you for your patient hearing. We are at the cusp where we are appreciating the beauty of nature through a robotic hand. I thank you. Thank you.